Introduce Dr. Shreyasi Sharma. She is Director Fetal Medicine and Genetics Center in Sector 47, Gurgaon, a very close friend and a go-to person for any fetal medicine issues. She is MBBS, MD, DNB Fellowship in Fetal Medicine, and she has so many achievements to her credit. But the most important is that she is certified Foxy trainer for ultrasound, and she's received the APJ Abdul Kalam Azad Award in 2023 for excellence in fetal medicine. And her fields of interest are fetal medicine, fetal interventions, fetal ultrasounds, high risk pregnancy, RH isoimmunization, and genetics. So, over the stage to Dr. Shreyasi Sharma.
Thank you, Dr. Sonal, for such a lovely introduction, and a very good morning to everyone. So, in the next 15 minutes, I have been given the task of covering the evolving trends and expanding horizons of fetal medicine and the use of ultrasound in that. So, I'll be to the point, crisp, and make sure that I finish within 15 minutes. So, I'll give an overview, not going into the detail of every aspect. Coming to ultrasound, this is one modality which has rarely come to age right now. So, in the entirety of modern medicine, this is one modality which has evolved beautifully. If you see, from 1950 to 2000, in the 50 years, this is the first published image which we see over here. Give me a minute. This was the first published image of ultrasound that was a fluid-filled condom to what we see right now are the 3D, 4D images. So imagine the level of advancement that has gone through. We do know that it's a cornerstone for antenatal management. It is the bedrock. It contributes to phenotyping, screening, monitoring, and then, of course, the fetal interventions. But I'm not here to talk about screening, monitoring. The thing which I wish to highlight is the level of phenotyping that we can achieve right now. So when we talk of phenotyping, right now we don't talk of things like a cleft lip or palate. We don't really miss them. We pick them in the first trimester. I'm not here to talk about a limb abnormality. We should pick them up in the first trimester. But let me show you with an example what kind of abnormalities am I talking about. This was an absolutely unremarkable history. SGA baby referred because there was a little lag in the growth, and at around 22 weeks. If you see in this image, it's the penultimate toe which is curved inside. So it's a clinodactyly. Leave aside that, it's a digital dysmorphism in both the feet, bilateral, and then an SGA baby. We go ahead, perform an amniocentesis, and it's a 4q terminal deletion syndrome, which will lead to an intellectual disability. This is the 4D image, and it does give a clear depiction that this toe is not on the same plane itself. So this is the first learning point, that when we are talking of phenotyping, we are talking of deep phenotyping, not just postnatally, in fact in the prenatal period. And please remember that most of the genetic syndromes would not have a detailed prenatal phenotype described. So even that small subtle finding on the ultrasound is extremely important to us. Let's see another example. This patient was referred to us with a history, like with a diagnosis of an open fourth ventricle, which we do agree, but there was something more. If you see, the intactness of the occipital part of the cranial bone is not there. Come to the sagittal view, and you too may see that there is one very small area where the intactness is not maintained. And that's the power of 3D examination. And now you see, I'm not going into the posterior fossa details. This was an arachnoid cyst with an uplifted vermis, but this is a small occipital encephalocele which you can clearly see on the 3D image. Of course, this went ahead, got terminated, and we could not find the occipital encephalocele on an X-ray. So we went ahead, performed a CT examination, and look at the level of characterization. It is just the same as what we saw in the 3D ultrasound. So that's the learning point too. When we are talking of deep phenotyping, it is not just 2D. And when we are talking of 3D and 4D ultrasound, it is not just aesthetics and entertainment. It does contribute to the medical diagnosis. When we are talking of phenotyping, we are not really limiting ourselves to the second trimester. We are going on to the third trimester also. For us, every scan is an anomaly scan. We don't really do just a growth scan. This is one scenario where the patient gets referred to us with an unexplained polyhydramnios, or we see there is a micrognathia, a microstomia, and of course a polyhydramnios. Now, look at the baby and just see this ultrasound description. Diffuse joint contractions, flexed arm, clenched hands, overlapping fingers, as we can see, and micrognathia. This is a condition which you diagnose right on ultrasound. You don't need anything else. All the fetal medicine specialists sitting here would know it is fetal akinesia deformation sequence. Again, a lethal abnormality which could have been picked earlier. So this is the postnatal image, and look at how clearly it is depicted on the ultrasound and the postnatal image. So that's the learning point 3, that whenever we are saying unexplained, it is usually under-evaluated. So make sure that you're also looking at phenotype in the third trimester. But we really don't want to, prolong and take things to the third trimester. We want to diagnose them early. I won't go in the details. I want to just make sure that you understand that a decade back, this guideline was published, and this was the scope of seeing on an ultrasound. And just a decade later, ISWAG updates the guideline, and all this we can see on the ultrasound now. So that's the sheer volume of it. And if you ask me which are the key structures which have improved, where we can have a better detection, is the heart and the brain. So these are a couple of our publications. So this is a body stalk anomaly. The abdominal wall goes into, there's a defect, goes into the coelomic cavity, amelia, and a neurotube defect with kyphoscoliosis, an anencephaly, which you will definitely diagnose in the first trimester where the nape of neck is missing, another of our publication. But again, I started with deep phenotyping, and this alone is not the scope of diagnosis in the first trimester. If you look at this image, it is done at 11 weeks. This 11 weeks, there is bilateral microphthalmia, bilateral cleft palate. We can diagnose it at 11 weeks, and this is a 3D rendered image of the same. You look here, this is a polydactyly in the first trimester. If you're wondering why the blood is going out of the heart, it is a cardiac diverticulum diagnosed in the first trimester. This is pleural effusion, and this is a hypoplastic left heart syndrome. So in all these scenarios, you can take the decision right at 11 or 12 weeks. And that's the learning point 4, that that's when we say we are expanding the horizons. We are not just limited to the usual stuff we have been doing since ages. The level of precision that we achieve now is quite in detail. I'll quickly shift gears and come to what's happening in the cardiac evaluation. For years, there have been researches, and we've come to a and see the structure extremely in detail. So we can nicely USG, all these things we can pick up. But where is the problem? It's the function of the heart, especially the fetal heart. So there are the methods like Doppler or M-mode assessment, but then not one single individual method can really give you a proper assessment of the function of the heart. It's usually a conglomerate of multiple things that we use. But what's new? What's the new thing? That's called speckle tracking or heart quantitative evaluation, which can be also superimposed on a 4D. I won't go into the details, but just to give you an idea, in an adult, this is routinely used. Like, just imagine if there's a myocardial infarction, just that part of the myocardium is having a poorer contractility as compared to the rest of the myocardium, and that the cardiologist can pick up. So what are we doing? In both systole and diastole, we are kind of creating 24 segments of the entire ventricle, and then assessing multiple parameters out of it at the global level and the segmental level. So this is how we can plot the entire graph for all the segments. See, evolving trend is one thing, but we really don't believe whatever we see. The next step we do is to validate, and this is our own study which was published in the international journal last year. So we evaluated and we were quite amazed that it works really well for global morphometric measurements for something like a stroke volume and a cardiac output per kilogram of the baby. I'm also pleased to share that this has been accepted in the upcoming World Congress, which would be held in Prague this year. Then, as clinicians, you would ask, does it really help us anywhere? Well, there is a lot of evidence which is evolving that, there is an HQ analysis in the smaller hearts of the babies where, it's an SG or an FGR, the heart might be more globular. But then to translate into real practice, there's still time, and that's the learning point 5, that it is a newer technology, we should be knowing about it, and it's promising. The last section is about the brain. What about the brain? For traditionally, we have been very happy that we are seeing, the axial sections of the brain. But then is that all? That's not all, The power of ultrasound is we can go look at the coronal views, look at the mid-sagittal and the parasagittal views, and that's what is called a neurosonography. For those who are wondering when should I really order that to my patient, then these guidelines, if you see, they are published quite long ago, way back in 2020, and then these are the indications where you can go ahead and prescribe this to your patient. If I have to classify, I would say where you actually suspect a CNS abnormality, when there is another abnormality in the heart, or specifically when there is a VOUS on the microarray. And at this point, I have seen myself asking in multiple forums that in the last 6 months, how many of you have really ordered a fetal echo? And I'm sure it would be 100% raise of hands. And if I ask how many of you have prescribed a neurosonography in the last 6 months, and I see only 1 person or 2 people raising the hand. So, it clearly depicts that matters of heart are always more closer and they supersede the matters of brain. But that should not be the case when it comes to clinical practice. And when you're talking about expanding the horizon, then we go up to the first trimester, and then we can diagnose things in the first trimester itself. Just one small example by which I can tell how neurosonography helps. An unremarkable history gets referred to us at 28 weeks for an abnormal MCA Doppler. We see MCA PI is fine, she was referred for an abnormal CPR, but then MCA PSV was raised, and there was polyhydramnios, an AGA baby. We go further and see that in the periventricular area, it is a little brighter. There is periventricular hyperechogenicity. And when we do a neurosonography, we see that the entire lateral ventricle, it's going along the length of the entire lateral ventricle. So I won't go in the details of that, but then overall there was fetal anemia and cranial findings. We went ahead, did an intrauterine transfusion after we had a normal infective result and normal results for infection and fish. And then, we could raise the fetal hemoglobin. Things were fine, but then the whole exome sequencing revealed that it was a primary coenzyme Q10 deficiency, again a lethal disorder diagnosed in the 3rd trimester. So what does that leave us with? It leaves us with a thought of a possibility if we would have not done a neurosonography. In that scenario, mostly it would have been either a prenatal or a postnatal demise or a hydrops, and autopsy might or might not have been offered or opted for, and in that case the diagnosis would have been made only if the next child gets affected. So that's the learning point 6, that a neurosonography is an immensely useful yet an underutilized tool. And this would be the last slide. Of course, it is the bedrock for performing fetal interventions, whether it is something as simple as doing an amniocentesis or a fetal transfusion, draining the thorax, which is thoracocentesis, or here we are putting a vesico-amniotic shunt. So it does form, really forms the bedrock, and this would be the final learning point. It's a very strong tool. It should not be just restricted to looking at the umbilical artery Doppler, and that's the final learning point, that its optimum use will help us optimize the outcomes. Thank you. I think that's my time.